one of the best anterior segment surgeon that I've seen in recent times, not only here but also abroad. He is professor of ophthalmology in VOPHA Teaching Hospital in Lahore, and he's well qualified and served. He has got a fellowship from College of Physicians and Surgeons Pakistan, as well as Royal College of Surgeons and Ophthalmologists from United Kingdom. And he is going to talk about trabeculectomy and its complication and everything, and its management. So, and the other thing is that apart from that, he is a great surgeon. Mazhry साहब is also a poet. ये शायर भी हैं और माशाल्लाह इनकी एक दो किताबें जो हैं वो भी पब्लिश हो चुकी हैं. So such a privilege, Zia, to you, please. Thank you very much for talking to us from Lahore. Thank you.
Thank you, Professor Mar, for using nice words and introducing me as a poet ophthalmologist. And we have chosen an interesting topic today. That's learning and teaching trabeculectomy. The background behind choosing such a topic is that it's always a privilege when Professor Maher invites and calls. And mashallah, he's the leading glaucoma specialist of the country. And he may agree with me that in our junior consultants and residents, the art of trabeculectomy and surgical interventions in glaucoma is on decline. And we have seen in recent times that the juniors are becoming reluctant to intervene because of the advent of modern medical therapies. The kind of the profession and the industry has pushed a concept that we have become too resistant to opt for surgical interventions, even when it's really indicated. That's why I have chosen this topic, because I feel that we need to popularize the trabeculectomy, which is the gold standard, as well as our other glaucoma interventions. Where they are indicated, one should not be shy to offer with well-explained prognosis to the patient, and with timely interventions, one can save sight. And it can be a difference between seeing and not seeing. And as Professor Mar introduced, there is a little poem, Chalo Phir Muskurate Hain. This is an occasion of the new year, and I feel honored that we are starting our new working day with a discussion on academics and be part of grand round of ophthalmology by Aga Khan University, a prestigious institution. So we start this new year with a poem about new year. नई उम्मीद बुनते हैं, नया जज्बा जगाते हैं. Let's build a new hope and we start the year with a new passion. कि रंजो गम भुलाकर हम चलो फिर मुस्कुराते हैं. नहीं मिलता महताबा अमावस है तो क्या गम है. If we are not able to find the full moon and it's a dark night, nothing to worry. कोई तारा कोई जुगनू कहीं से ढूंढ लाते हैं. Let's find a star or a firefly from somewhere. न होने देंगे मध्यम हम चरागे आरजू की लो, के रोगन की जगह यारो ये खूने दिल जलाते हैं. चले आओ के मिल बैठें प्याली चाय की पी लें, खुनक शामे दिसंबर को हसीन दिलकश बनाते हैं. वो बातें बीते वक्तों की, वो यादें खोए लोगों की, चलो मिलकर तसव्वुर में ख्यालों में सजाते हैं. जो अपने बस में है यारो वो तो करते जाएं हम, दिलों के जख्म भरते और रोतों को हंसाते हैं. ये साले नो की सुबह है ज़ियाउल मज़हरी आओ, नई आसों मंगों और दुआओं से मनाते हैं. So glaucoma surgery, everyone is trying to do something because we know that the standard trabeculectomy has limitations. So that's one reason that we are getting shy of the interventions, because it's not as predictable as we have seen in recent times. The phaco surgery has become so much reproducible and predictable. And that shows my topic of interest as well. That if we discuss the trab and we make it part of our discussions, then we can customize trabeculectomy as well. Like we refine our phacosurgery, let's focus on our glaucoma interventions and customize them in a way that they also become reproducible and predictable in our hands. And that's one of the topics I always discuss: customize your trabeculectomy. So indications, very simple. What is a controlled glaucoma? If the visual fields and the OCT changes are stable, the pressure is in control with one or two bottles or combinations. And when we start thinking that the glaucoma is not in control, when in spite of 3 or 4 bottles or 4 glaucoma agents, the visual field and the OCT changes are progressing. And I always remember Professor Abdul Jalil Dawla here. He used to say that when you need to add third glaucoma agent, you should start thinking of surgical intervention. And when fourth drug or astazolamide comes into the picture, that's an absolute indication of trabeculectomy. As we know that in our generation, in our races, the tolerance to oral astazolamide is not very good. So when oral acetazolamide comes into picture to control glaucoma, that's a time to think about surgical intervention. So incisional surgery may be penetrating, non-penetrating. We are not going to go in detail. The adjuvants which we use are mitomycin C is top of the list, and then there is 5-FU and others. Drainage implants are there in the picture. Then role of cataract surgery in glaucoma management is in itself a topic, because in narrow angles it can really be a game changer by deepening the angle and controlling the IOP. And it is well established now that about 2 millimeters of mercury can drop even with regular cataract surgery. The options are: you enhance outflow by handling physiological pathways like trabecular meshwork, or by Schlemm's canal manipulation, or using some devices in suprachoroidal space. And subconjunctival drainage, for that trabeculectomy is the gold standard, and recently aqueous drainage devices are also becoming rapidly available in the market, which use subconjunctival space for drainage purpose. And in some cases where none of the procedures is possible, we can reduce the inflow by endoscopic or external cyclophotocoagulation, or cyclodiode ablation, or micropulse diode ablation. And similarly, as I mentioned, we can always think of combining phacoIOL surgery with cataract surgery. And reviewing all the procedures, there was an article in iNet magazine by American Academy of Ophthalmology with the name "Trabeculectomy is the King." Trabeculectomy is like a sphygmomanometer, which is used to standardize all the procedures. The success of any procedure or a device is defined against trabeculectomy. And if we are able to refine and customize our trab, probably the glaucoma management and interventions become easier. And especially in some part of the world where the people are not lucky to enjoy the modern devices and costly interventional knives, this gold standard trabeculectomy becomes really, it becomes prudent to learn and teach trabeculectomy as our topic of today. So in this discussion, we will be understanding the essential principles of surgery, and we will be touching prevention of complications and a little insight on how to manage, and then recognition and management of intraoperative problems. And as we start step-by-step approach to our trabeculectomy with antimetabolites, that is mitomycin C, the first thing is, and the most of these guidelines have been standardized by Moorfield safe surgery technique. And the recommendation is that one should avoid using superior rectus suture if possible. And my own preference is that I seldom use traction suture. And if needed, we can use 60 or 70 Vicryl or silk suture, taking about a bite from the superior limbus, as you can see here, about 80 to 90% depth of the cornea, and we can pull it downwards to get a rotation. But my own preference is that to use no traction suture in most of the cases. The other thing is that the preoperative anesthesia, it should be minimal, and the preoperative preparation, one should also consider that we have to take the eye to the operation theater with relatively normal pressures. We can minimize the wipeout phenomena, that is losing the vein on operation table, if we control the IOP beforehand. And we may use injection mannitol on the day of the surgery, but by the glaucoma drugs and by oral acetazolamide, we should try to keep the pressure in check and in normal range, if possible, for 1 or 2 weeks before the surgery, so that the choroid and the intraocular tissues behave well during the surgery, and the risk of the hypotony and the suprachoroidal bleed and wipeout are minimized if we take these preoperative precautions. And as long as anesthesia is concerned, either we may use topical anesthesia with local subconjunctival infiltration, or we should use minimal peribulbar injection of about 2 to 3 cc only. And we need to be very careful and gentle. We should not use balloon and other devices, because the optic nerve and having such an uncontrolled glaucoma, the axons are already compromised. So we must take a precaution not to let the IOP raised above a certain level. And after we have exposed, the next thing is conjunctival peritone. So the discussion is always here on limbus versus fornix based flap. Most of the consensus recent years have developed on fornix based flap because it's easy to manipulate, to cauterize and to fashion scleral flap and sclerostomy opening with this technique. And the concern why the limbal based flap was popularized was because of the leakage. And with modern guidelines and proper closure and proper fashioning of the wound, the risk of leakage and hypotony and proper suturing techniques has been minimized. So that's why most of us agree now that, and this is my practice, that I use fornix based flap peritomy, and the size of the peritomy should be just enough to fashion a good window. It should not be very big, and as you can see in this graphic, that there are no relaxing cuts on the side, and very fine scissor should be used, as you will see in the next. And the second thing about this peritomy is that your conjunctival peritomy should be just at the limbus, right at the limbus. We should not leave any conjunctival frill while cutting the conjunctiva, because limbus is an ideal structure to close, because the healing and approximation will be excellent here. So just along the limbus we need to cut it. And the second thing is that this dotted line is showing where we are aiming to raise our bleb. It should be white, and we should use the blunt dissection scissor to enlarge it supranasally as well as supratemporally, so that our peritomy at the limbus is just enough to maybe around 6 to 8 millimeters or 10 millimeters, not more than that. Rather, 6 to 8 is enough. But the area of drainage should be wide enough for a diffuse bleb formation and mitomycin application. That is, the conjunctival pocket should be fashioned in a way for a wider drainage area. And the cautery should be just enough. Very interesting. In this diagram, the cautery is just there around the limbal area and then along the line of incisions for partial thickness scleral flap and sutures. But the point here is that we should not leave any bleeders, and at the same time there should not be any charring. Any brown sclera is a indicator that we have over-cauterized. So it should be just enough. As you can see in this video, that you just hold the conjunctiva near the limbus and a traction line appear, and then we may use here a forceps, holding forceps with blunt teeth. So I'm just cutting the conjunctiva along the limbus, and once I feel that the peritomy is enough, then the conjunctival pocket is being dissected again with the blunt scissor, and you may have seen that we are pointing the blades towards the conjunctiva, and we take the tenon along with the conjunctiva as well. We can just rotate the conjunctiva and hold it from the inner tenon side for a better grip. And thus we have completed the peritomy, and at the same time we have fashioned a good conjunctival pocket for mitomycin C application. And here comes the cautery. I personally perform the cautery up to the whole scleral bed and the suturing area, but the point here is that the conjunctival flap margin should not be touched, and sclera should be just white, and no brownish discoloration should be there, which shows charring. Then comes our previous technique of application of mitomycin C sponges. We always count them and we insert them. There is a recommendation that a single sponge may be used, but we have found that we count the number of sponges and we fill the whole pocket, and then we hold the conjunctiva gently and give it 4 to 5 minutes as per recommendations. And this is one technique which we used to use. Recently what we are doing is that we are performing, the concentration used to be 0.3 to 0.5%, 0.05%, and recently we are using the concentration of 0.1 to 0.2, and then we remove the sponges and rinse it thoroughly with the Ringer's lactate or BES solution. The other option is that before draping we inject injection mitomycin C 0.01 to 0.02 gram percent into the bleb area like this, and as you drape and get ready, it is diffuse, and then comes a scleral dissection. I perform the initial incision, that is about 5 millimeters, and then a sharp crescent hockey knife comes into the picture, and my preference is that I just do dissection first and then perform the lateral cutting of the sides with the help of a venous scissor. And then for the deep Cyclerosmi, I use a little my own innovation, that is traction suture. I spread the viscoelastic over the cornea and just a partial thickness bite from the flap, and I hold it at the limbus. It makes me free of dependency on my assistant hands and gives a very good exposure for deep sclerostomy. 2 vertical cuts along the side, straddling the limbus and into the clear cornea. I keep on dissecting it gently until I am sure that it is full thickness. And then I join these 2 cuts and make it all dissected, and finally I remove it with the help of a forceps and a scissor. This is the sclerostomy. Generally I avoid cauterization here, but if there is a bleeder we can use it. And immediately the iris is prolapsed, or you can tap the sclera to get the iris bulge out and hold it and perform a good iridotomy. Then comes the suture application, and preference is either you can use permanent sutures, and you can keep in mind that you may need to cut it with lasers or may need to relax them with a needle later on, and you always bury the knots. And the closure needs to be tight at this point. That's where you can avoid hypotony. One should leave the AC well formed and the pressure should be between 10 and 20. And then we take a long bite from the limbus and from the partial thickness cornea, and this suture is very crucial as long as the postoperative leakage is concerned. By taking a deep and long bite from cornea and then involving the conjunctiva and applying the suture, you see there are little folds in the cornea while we are passing this needle, and while we approximate the conjunctiva tenon and we apply and tighten it, you can see there is here is a crease, a kind of depression along the line of the closure. And as we have taken a deep long bite, so it becomes easier to bury these sutures as well. So this is how I personally have customized and performed my trabeculectomy. As you can see, after cauterization, the graphics, this is the area of scleral spur and the dissection goes into the clear cornea. But on the lateral side, we try to avoid cutting the cornea. And side cutting is performed with scissors. This is again the scleral flap dissection. The crescent knife is being used to dissect it. It will appear under the clear cornea, and then the side cutting will be performed like this, and this completes our partial thickness flaps. And as you have seen in the video, the deep sclerostomy involving the clear cornea and the sclera and straddling the limbus has been cut from all sides. You can use a punch here, but I use either 15-degree blade or ambia blade or an 11-0 blade and a scissor to complete this, like shown in the graphic. And then you can just tap at the sclera to let the iris bulge, hold it, and perform a good iridotomy. And you can use the flap retraction suture, which can really facilitate, as you have seen, that we just pass a partial thickness, take a bite part from the scleral flap, and we just tie it at the 6 o'clock limbus, and it gives a very good exposure for your deep sclerostomy, and you are not dependent on assistant hands. Little part of the sclera, more of the clear cornea is taken into the window. It is fashioned from posterior to interior side, but some surgeons recommend that you may cut it from the interior part first and posterior in the end. It's whatever the way you like. And the closure, as we have seen in the video, that you need to apply here tight sutures, and our desire by fashioning this quadrangular flap is that we want a posterior drainage. We don't want a sideways drainage here. And while we close it, we can use simply releasable suture with 4 throws, in which we take the bite first from away from this, and we go appear at the limbus, and then we again pass through the corneoscleral junction and appear here, and then we apply these sutures. Or we can apply permanent sutures, but we have to keep in mind that if the pressure is not in control in 1 or 2 weeks after the surgery, we may need to release one of the sutures or cut one of the sutures with needle or lasers. And this was the conjunctival crease I was mentioning, that as you apply these conjunctival closing sutures, it should be tight enough so that a little crease appears on the conjunctiva and a little fold may also appear on the cornea. Then the risk of leakage will be minimized. So we have discussed all these things. Knots are all buried in the deep as well as in superficial conjunctival sutures. So how can you prevent hypotony? By firmly closing the scleral flap. We can test the flow after the closure. It should be just a drop every 10 seconds. Then we are fine. And meticulous watertight closure of tinea and conjunctiva is also advisable. I do it in one layer, but some surgeons perform it in separate layers as well. And generally, if we are quick, the AC forms by itself, or we can use paracentesis to form the anterior chamber in the end. If there is a pressure is not enoughly controlled in postoperative period, the first thing we offer to or make the patient understand is AC compression, and we perform it in the at the slit lamp, and we advise the patient to perform maybe 10 compressions 3 times a day, and if we keep a watch. So that's what make the trabeculectomy different from a regular phacosurgery. We may need to see the patient many times. We may need to perform AC compression in the office, and we have to keep an eye on the leakage as well as IOP parameters, and we keep on offering from mild to moderate to severe or whatever, a little to more extensive interventions whenever needed. We may need suture lysis, or just if we have applied relievable sutures, we may need to remove them. And rarely we have to perform bleb revision with needling, and we may inject mitomycin C or 5-FU in the bleb later on as well. And even the years later, we can perform these needling procedures. It's very simple. We just enter into the conjunctiva a little away from the bleb area, and then we visualize the needle underneath the bleb, and we use the bevel of the needle by rocking movement to keep on dissecting the conjunctiva. And while we perform this maneuver, this bleb revision should not be combined with injection mitomycin C. We have to make them separate. Either we just go and inject injection mitomycin C, then we should not enter the anterior chamber. If we do it in 2 sitting, first we can simply revise the bleb by this rocking movement, and we can revise the deep scleral flap by seeing the needle in the anterior chamber. At that time, we should not use injection MMC. We can consider the antimetabolite injection later on.
Bismillahirrahmanirrahim.
So this is a summary
presentation. I'm going to explain how to customize trabeculectomy with injection mitomycin C, and I'm going to show you various customizations which I have made to make trabeculectomy with mitomycin C easy for me, and hopefully it will help you to make your trab easy as well.
Recording stopped.
Glaucoma surgery everybody is doing, coming up with stents and different devices. but still trabeculectomy is the king. So let's try to refine and customize it. The first step is the conjunctival flap making. My preference is fornix based because it helps dissection, cauterization, and resembles our regular trap. And the size may be about 6 to 8 millimeters cut, and deep blunt dissection is performed. The assurance is made that the margins are not torn, and deep dissection on the sides is also performed. Then comes a point, application of injection mitomycin C. This had been our routine, that we prepare the conjunctival flap and then perform a good cauterization.
Recording in progress.
And the soaked sponges with injection mitomycin C come into the picture and are placed one by one in subconjunctival space. This is my routine. I used to apply it before scleral flap dissection, and then you need to hold it for 3 to 5 minutes depending upon the kind of fibrosis you expect, and then you remove the sponges and flush it. This is had been our practice, and this is a modification I've been using for quite some time now, that I just inject the injection mitomycin C into the subconjunctival space 3 to 5 minutes before starting the peritomy. And then peritomy is performed and the rest of the trap is completed as such. So this is one modification which has facilitated the procedure a lot, because you 3 to 5 minutes of holding it and risk of touching the margins is no more there, and the results are very good. So the section of the conjunctival flap, we use crescent hockey knife. It makes a life easy. You can use diamond knife as well, and it almost straddles the limbus both ways. And then side cutting is performed with the help of scissors, and a nice 1/3 or half thickness scleral flap is ready. And I have developed and been using this flap retraction suture at this stage to have a good exposure of the deeper tissues for deep sclerotomy and peripheral rhodectomy. I just pass a 10-0 nylon suture partial thickness through the tip of the scleral flap and secure it at opposite limbus, and the cornea is well covered with the viscoelastic material and is washed as well. So this maneuver facilitates an assistant-free, hassle-free dissection of the deep sclerotomy and peripheral rhodectomy with ease. And once we have completed both the steps, the retraction suture is cut and removed. Then comes the closure. I have rectangular flaps generally, and I use 2 sutures, taking long bite from the scleral bed and applying 2-1-1 knot, and then I always bury both the sutures. So this is how I close the scleral flap. And then comes the conjunctival flap. For that, I take a deep bite from the cornea and a long bite so that I can apply a good traction on both the sides of the conjunctival flap. And this suture is very important. We need to debride the epithelium and take healthy tangential bites and then assure that it is snug and very tight. Even there may be some corneal folds. And that assures that there is no post-op leakage and the healing is very good. And generally, I don't apply any stay sutures in between. So this is the quickly summarize the steps. The injection mitomycin has been diluted, has been already injected. The cauterization is performed.
So we have already summarized the things, and this is a very classical diagram. As you can see, the conjunctival peritomy has been performed, and then large scleral flap is fashioned, and it should not be cut at the limbus, just it should be enough near to the limbus. And the pocket has been diffusely dissected. As we have seen that we are aiming a posterior flow and in a wider area of the conjunctival pocket, that is posteriorly directed flow. And we have prepared a large treatment area, and we may use tight adjustable sutures to avoid hypotony and other complication. We may use a punch, or we use traction suture to fashion the deep sclerostomy as we have done. And these are the two references, one which reviews the Moorfield safe surgery technique, and the other one is which shows with graphics and animations a beautiful summary of trabeculectomy by American Academy of Ophthalmology. And नई उम्मीद बुनते हैं, नया जज्बा जगाते हैं कि रंजो गम भुलाकर हम चलो फिर मुस्कुराते हैं. Thank you very much. Now hopefully we are open for questions. Please chat. Mariam? Madam Mariam? Can you hear me? Hello, sir. Professor P.S. Mer, kindly unmute your mic. So there is a question that if buttonhole occurs in scleral flap, how to deal with it? You can just suture it if it is small, but if it's a big hole or you have torn the scleral flap, you may need to raise a partial thickness flap from the side to cover it. And then there is a question about how do you decide the dose of mitomycin C and for how much time? Is there any criteria? Yes, in younger patients where conjunctiva tenon is quite thick, you expect more fibrosis. So you may go to 0.3 to 0.4 gram per 0.03 to 0.04 gram percent dose and apply it for 4 to 5 minutes. But generally we are using the same methods now because it was a more of a concern once there were used to be hypotony and leakage. With modern gold standard guidelines, the complications have been decreased, and we just follow the same. That is, if you inject it pre-op, as I mentioned before draping, then the dose is 0.01 to 0.02 gram %, and if you use it during the with microsponges, then the dose is 0.03 to 0.04 gram % for 4 to 5 minutes. What is the ideal size of conjunctival bleb, not scleral bleb? That is a question from Suhail Bukhari. So the conjunctival bleb should be around maybe 10 to 14 millimeters and diffuse ideally. How to clinically assess that bleb is going towards the failure? These are the simple measures, like the biggest criteria is intraocular pressure, and if it is raising, and our objective here is to bring it target pressure, that is as near to 10 as possible, because we are already discussed that we are performing in advanced cases. So there is not big magic or a big science here, just bring it to 10, as near to 10 as possible. And if the pressure control is not enough, that shows the bleb is failing. And there is another questions, if there is a scleral flap avulsion, how to deal with it? We have already discussed that we can re-suture it, and if it is too thin or wasted, then we may need to raise a partial thickness scleral flap from infratemporal quadrant to bring it there and cover the deep sclerostomy. There is another question, that if you advise ocular digital massage in every case, or if bleb is failing. Yes, we advise the ocular digital massage only if the IOP is not in control. So as I already mentioned during the discussion, that this is where the trabeculectomy and the glaucoma surgical interventions differ from phaco and other regular procedures, that you have to be very vigilant. You may need to see the patient daily in the first week if needed, and we keep on monitoring. If the IOP is well in control, the chamber is formed, there is no hypotony and no raised IOP, we don't advise any massage or any intervention, just a regular steroid antibiotic topical combination, and we keep on observing. But if there is raised IOP and it is not enoughly controlled, then we perform first the digital massage at straight lamp, and then we advise the patient, and then our observation becomes more close. If we are happy that the IOP is well in control, there is no leakage, AC is well formed, then we can call the patient after 48 hours. But if there is some problem, we see the patient every 24 hours, and some of the surgeons even advocate that we remove the bandage on the same day and have a look in the evening, just after 6 to 8 hours, just to avoid the complications. So these were the few questions asked by the audience. I request Professor P.S. Mahar for comments, please, and share his wide and great experience of glaucoma interventions with us. Professor P.S. Mahar, kindly unmute your mic, please.
Thank you very much, Mazhry. Actually, मेरे जो अनम्यूट था वो मरियम के हाथ में था और मरियम मेरे ख्याल में सो गई हैं. Anyway, that was very kind of you to deliver this lecture. I think we do the trabeculectomy almost in the similar fashion. There are always modification. I like to do the fornix-based trabeculectomy because also I find that it's easy to teach to your residents. And then I make majority of the time triangular flap and clear cornea, less cautery. MMC for last several years now, I've stopped putting sponges and use injection mitomycin C. And normally I don't do it 3 to 5 minutes earlier. I do it when I start the procedure. Just do a small opening in the limbus, inject it 10 millimeters away from the limbus, and then carry on with peritomy. And then once this is done, you make the pockets, and then you wash it out with about 20-25 minutes of balance or solution. And the rest is same. I use normally punch Zia, but of course you are making this window, which is okay. And this is it. And then idea is to make it as tight as possible, because in the post-operative phase, you can always go and remove these sutures. I normally put sutures that I can lyse them with organ laser. And I don't want to see my patient in hypotony. And there are two things I don't want to see. Number one is I don't want to see them in hypotony. Number two, I don't want to see the anterior chamber flat. So sometimes, in fact, majority of time I leave viscoelastic substance in the anterior chamber. So the pressure is almost 18-20 on the first day. And then if you just follow it carefully, it keeps on coming down. And then, of course, you told the importance of ocular digital massage, which is very important, because if you see the pressure going up, you can do the massage. That will tell you that there's a mechanical obstruction and you need to release enough suture. So the technique is almost the same, but there are always modifications, and you do it according to your wishes and how you find it success in these cases. And of course, I enjoyed that comment from you that this is not like a phacoemulsification where you do nice surgery, send the patient home, and then everybody is everything is hunky-dory. It's not. So the problem starts when you've done the surgery, and then you want to make sure that your trap works. So also, I would like to ask you, what is your post-operative treatment plan in these cases, Zia?
Sir, we generally apply the bandage and open it on next day, and then we perform the Seidel test and the IOP measurements, and then the further planning depends upon the findings. If the IOP is well in control, the chamber is well formed, there is no hypotony, no leakage, then I call the patient after 48 hours. And if there is any problem, the pressure is not in control, then I perform the massage at the straight lamp and advise and make the patient understand how to do it. Generally, we ask them to look downwards and apply with their index finger. Then just keep on applying the compressions, like 10 compressions every hour or 10 compressions 3 times a day, like that. And then we keep on following. If once it always varies, there is no standard protocol. If everything is well settled, then we call the patient after a week, and then we can go for a weekly follow-up for first 4 weeks, and then monthly follow-up, and then once everything is settled, then as we do a regular follow-up with glaucoma patients, that is, we check the IOP and all the conditions every 3 months. And generally in our setups, whatever the procedure we have performed, whether we have intervened or not, I follow my glaucoma patients like that I check their regular things every 3 months, and I perform their detailed glaucoma workup, including visual field, OCT analysis, and fundus photograph after every year. So
how long you use the steroid in your patient?
I use it for about 4 weeks.
Dexamethasone?
Yes, dexamethasone antibiotic combination.
Okay, so you stop them after 4 weeks?
Generally. What's your recommendation, sir?
So I use them for at least 10 weeks.
10 weeks.
Because the local population, we used to use it for about 6 weeks to 8 weeks in, people, Caucasian people in UK. But here, our fibroblastic turnover is very high. This is the reason I use them almost 10 weeks to 12 weeks. And also we want to look at the conjunctival vascularization very, very carefully, superiorly over the left side. And if it's still there, maybe we can even go beyond that, But we want to make sure that there's no vessels or dilated, congested vessels over the superior conjunctiva, and that causes problem in the fibrosis and the blade fails later on.
So whenever we have a session like that, the speaker is the real beneficiary. So I am the real beneficiary of today's discussion. I'll make it 8 to 10
No.
weeks. It appears quite logical that we keep on watching the vascularization, and if we can give it a cover with even mild topical steroid for about 8 to 10 weeks, I agree with Professor P.S. Mahar. So this is what I tell my residents, that whenever I present or I take a responsibility to come on the podium, I am the one who has learned the most from that discussion, because it leads you to go into the literature to review, and then you benefit from the icons like Professor P.S. Mahar as well.
I think you are very gracious saying that, it's not that one, we have learned from your presentation, small point. We always learn,
Alhamdulillah.
Learning never ends. Learning never ends.
That's
okay.
Right.
Is there any other questions from the audience, please?
As long as the chat box is concerned, there are no more questions or comments.
Okay. Okay. If there's no comments, I just want to thank you very much, especially on Monday cool morning that you come and speak to us. I really appreciate your allocating this time and about an hour to talk to us. I really appreciate it.
Thank you very much, sir, for your kindness,
Recording
for inviting, and for everything.
Okay.
Okay.
Thank you. Thank
Allah
you.
Hafiz, sir.
Thank you. Khud Hafiz. Khud Hafiz.